Hello and good evening, everyone. I'm Mazen Noureddin. On behalf of CME Outfitter, I would like to welcome you to our talk tonight, a deeper dive into Nash diagnosis and treatment and augmented reality experience. So as you know, this program is brought to you by CME Outfitter, an award-winning educator around the world. And as you know, this is a CME eligible program, and you will also get ABIM mock points. So what you need to do at the end of this program, you submit the paperwork to CME Outfitter, and they will submit it to the mock points on your behalf. So let me introduce the faculty for today. Again, I'm Mazen Noureddin. I'm a transplant hepatologist and the director of Fatty Liver Program at the Digestive Disease Division at Cedars-Sinai Medical Center in Los Angeles, where the ACP meeting was supposed to be, but now we're all over the country. And I'm actually very excited and privileged to present two people today. Let me start with Dr. Howell. Dr. Howell is a very experienced primary care physician, but also he has been the director and CMO for many health plans. He's very thoughtful, has been a leader in the field of health plan, healthcare planning, and we're very excited to have him tonight and see the opinion of primary care physicians and thought leaders like him. And from my standpoint, it's a great honor to present Dr. Zubair Younasi. He's the chairman of Department of Medicine and professor of medicine at Inova Fairfax Hospital in Fairfax, Virginia. Dr. Younasi has tons of publications, but in liver disease, and has led liver disease to the next step. But it's not just the number of the publication, it's actually the impact that he has done for the liver disease and the way he moved the field forward. So he's a great expert. Please feel free to ask him your questions today, and many of the publications today are coming from him. So let's start with the learning objectives of this program. The first learning objective is very important when you get these NAFLD and NASH patients in your clinic. How to identify risk factors of these patients. Not all patients with fatty liver are the same. So we will learn today how to identify the risk factors for these people. So before we start, I need to ask you a question. Now, I'm going to ask Dr. Howell, there's a patient knocking on his door. His name is George, and I would like to ask Dr. Howell to present this case.
Mazen, thank you so much. As the primary care physician within the group, the gentleman George is a 59-year-old Mexican American, and just a very prototypical type of patient that we all see on a daily basis. And within that, this gentleman has type 2 diabetes for 5 years, dyslipidemia, that was diagnosed 2 years ago, family history of diabetes and hypertension. And from a social history, he's out, he has limited exercise, drinks, occasionally socially on the weekends. And, as an attorney, of course, he's an attorney, he has to entertain clients and he's, eating a typical westernized style diet. He also has a little bit of obesity, a BMI of 33. And then upon, history, he mentions that he has some, right upper quadrant discomfort. Medications currently that he has is metformin twice a day, and he actually takes fish oil. But this gentleman is just your typical, person that comes into your office, and we probably see 8 to 10, people that look just like George every single day. And then with this, we have laboratory values that belong to George. And when we look at his laboratory values, it's kind of interesting. His ALT and AST are slightly elevated at 60 and 65. His AST is a little bit higher than his ALT. Billy and albumin are within normal limits. Platelet count is 180,000. And we would define that as being normal, but it's slightly above 150,000. HDL and LDL, they're basically kind of within limits, given that this gentleman's a type 2 diabetic and his hemoglobin A1C is 6.9%. And so a little bit above where we would like it to be. We would probably like it, within better control, considering he's only 59 years of age. And so looking at this patient in total, we can see this is the standard type of patient from the questionnaire in the beginning that we would see within our offices as primary care physicians.
This is great, Scott. So George is about every other patient or every third patient you see in your clinic. Now, we would like to know, what would you like to do on these patients? Dr. Yanasi. Now, a lot of primary care physicians ask us, is this real? How prevalent? What's the problem? What's the scope of the problem and the magnitude? So you have published a lot in this area. We would love to hear about your work, and that included the entire world and the United States. So would you please tell us about this disease?
Yeah, thanks, Mazen. I'm glad to review some of the epidemiology data, and thanks for inviting me to be a part of this. So when you look at non-alcoholic fatty liver disease, which is basically having fat in the liver without any evidence of alcohol or other causes of fatty liver like medication or other genetic disorders that can cause fatty liver, that is really what is defined as fatty liver. The prevalence globally is estimated to be about 25%. This comes from a meta-analysis that we published a few years ago. The prevalence is actually varies according to geographic location. So the highest prevalence has been reported from Middle East and South America, and the lowest prevalence from Africa. What's actually interesting is that when you look at Europe, North America, and Asia, the prevalence rate is about 23 to 27%, not very different when you look across that part of the area of the globe. When you're talking about the prevalence of the progressive type of fatty liver disease, which is called Nash or non-alcoholic steatohepatitis, that prevalence is about 3 to 5%. That's the subtype, as I'll show you in a few minutes, is going to be the one that would be important to consider. Now, one group of patients that you would have to worry about more are those that have type 2 diabetes. The prevalence of type 2 of NAFLD in diabetics is about 55%. This is again from another systematic review that we performed. And when you look at those that have NASH within the diabetic population, about 67% of diabetics, when you biopsy them, they have NASH, and about 17% of those have advanced fibrosis. Again, there's a geographic variation of the prevalence of NAFLD, the highest prevalence being reported from South America, and again, Middle East, and the lowest prevalence would be from Africa. So when you look at the overall prevalence, so if you look at the biopsy of patients with type 2 diabetes, like I say, that 67% of those who are biopsied will have a prevalence of NASH. But there are additional data that suggest that about a third of diabetics will have NASH, will be at significant risk of progression. And in fact, when you have diabetes in the context of NASH, you have a significant increased risk of both having complication of cirrhosis in terms of mortality, but also hepatocellular carcinoma or liver cancer. One of the ways to actually estimate this natural history is to do a modeling. This was a Markov model that was published again about 2 years ago, and a number of us were part of this publication. The bottom line of this study is that when you look at the sort of profile of how NAFLD is going to change, the trajectory of NAFLD in its complication over time, you'll see that there is a doubling of the advanced fibrosis related to NASH. So if you look at the middle of the slide, F3, F4, that means advanced fibrosis. By 2030, in 15 years, it is expected to have doubling of these number of patients. In fact, number of deaths are going to increase quite a bit. Liver-related deaths are expected to increase by about almost 200%. And this is data that comes from the United States, but the same type of analysis has been done down for Europe, for Asia, for Middle East, and in every one of these parts of the world, the same type of data is being shown, suggesting that the global epidemic of obesity and type 2 diabetes is impacting the prevalence of NAFLD and also the development of complication related to the advanced form of NAFLD, which is non-alcoholic steatohepatitis.
Quite interesting, Dr. Yanasi. So what caught my eye is more than half of the patients that are diabetics, they come to you, they have NAFLD, and almost 2/3 of those, they have NASH. Now, a lot of doctors ask me that they're not hepatologists. What is NAFLD? What is NASH? What is the difference? If I put ICD code, their ICD code for both. So we thought that you probably can highlight the natural history in the next slide or so. So would you please walk us through the natural history of NAFLD and NASH, and what do I call what, and what do I put in the chart?
So non-alcoholic fatty liver disease, or NAFLD, is really an umbrella term. It includes non-alcoholic steatohepatitis. So steatohepatitis by definition means that you have to have histologic confirmation of fat, ballooning of hepatocytes, which is damage to liver cells, and sometimes you have this what's called chicken wire fibrosis or peripheral fibrosis. That is the type of fatty liver disease that tends to progress over time. There is the other type of fatty liver disease that is basic, does not actually fulfill the criteria for this NASH. The prevalence of that is probably higher than NASH in general, because as you can see, when you have 25% of general population having NAFLD, but only about 3 to 5% of them having NASH, then the majority of them have non-NASH NAFLD. Now, of course, can some of those patients that don't currently have NASH, can they progress? It's possible. The numbers are rare. It's really the one that you have to focus on is the NASH. And the NASH is the group of patients that can then develop into complication of cirrhosis, advanced fibrosis. The rate is about 10 to 25% over about a few years. And the rate of liver cancer is somewhere between 0.2% or so. Now, one of the peculiarities of NAFLD is that the progression to NASH and progression of NASH to different stages of fibrosis or scarring of the liver is not linear. It's basically sort of a situation where you have progression of fibrosis, then regression of fibrosis without any intervention. That's one important issue to consider. The second important issue to consider is that hepatocellular carcinoma, or liver cancer, primarily develops in the setting of advanced fibrosis and all liver diseases, including NASH. But in NASH and even NAFLD, without fibrosis and without cirrhosis, you can sometimes see development of liver cancer. So that's a major issue, but those rates are very low. So the only patient that we recommend screening are those patients that have advanced fibrosis with NASH. The third peculiarity of this disease is that although the NASH subtype, especially those that have advanced fibrosis, they have high rate of liver-related mortality. The number one cause of death in this group of patients is actually cardiovascular mortality. So it's important that you will actually address this not only for the specific cause of NASH-related cirrhosis and complication, but also in terms of cardiovascular mortality that these patients are at risk for.
Very interesting, Dr. Yanasi. Not everyone has NASH, but still significant number has it and they get to fibrosis. So let me move to you, actually. You are a primary care physician and you see a lot of these patients. Can you tell me how these patients actually present in your clinic and what do you see in your practice?
And thank you, Mazen. Just the gentleman that we presented, George, is the standard type of gentleman that we'll see, with a metabolic type syndrome. But one of the aspects being on the front lines is that, the first reaction that we'll get is just getting liver enzymes. And so abnormal liver enzymes may or may not help us with the diagnosis. And so when you really look at what the ACG considers like normal ALT, it's actually lower than what the range is within what we get from our standard laboratories. And so there's actually a little bit more and lower range that we need to look at ALT. And then what's really interesting is in the second two bullets, serum ALT can be normal in nearly 60% of the NAFLD patients with NASH, and then serum ALT can be increased up to 53% in NAFLD with no NASH. So that means that when we're on the front lines, we have to, just because we get liver enzymes, if they're elevated, that tells us one story, but it may not have as much predictive, value when we're looking at NASH or fibrotic level. And so we really have to have our awareness when we're looking at the patient, looking at exactly that metabolic syndrome patient with type 2 diabetes, with cardiovascular disease. And everyone looks at just the liver enzymes, but in fact, liver enzymes are, just a tough way to, make that determination. And it's only one piece of the puzzle.
This is very interesting. Scott, you mentioned liver enzymes unreliable all the time, although this is one of the first things looked at by GIs and primary care physicians. So I'm going to ask you first, and then maybe Dr. Younasi can tell us, how do you risk stratify your patients? How do you know like these guys have NASH and might get in trouble and have advanced fibrosis, maybe even cirrhosis with normal liver enzymes? So what do you do, Scott, from your primary care standpoint? And let's see the expert, Dr. Younasi, what he would do in a hepatology clinic when he gets these patients.
And thank you, Mazen. So the aspect that I see within this slide is that out of those 100 million members of NAFLD, my job is to help, determine who's going to have that 80% and who's going to have that 20%. And so understanding the people with the risk factors, understanding, people with that metabolic syndrome, with cardiovascular disease, and then understanding who's going to be that 80% and who's that 20%. Within that 20%, they can move forward to the hepatologist and gastroenterologist. And then what I'd like to do is allow the further on discussion, from that NASH going forward from the advanced fibrosis. But as primary care physicians, we're interested in that first wave, and then that second part will be all the referral patterns that are going on.
Very interesting. Dr. Younasi, how do you deal with these patients? Like, let's say everyone is coming to you, and how do you stratify them? Can you tell this one has NASH versus advanced fibrosis?
Yeah, I think that there are a few things that's really important to understand is that although I mentioned that only 3 to 5% of the general population have NASH, 25% have NAFLD, remember that hepatitis C prevalence was about 1.5 to 1.8%. So this disease, the NASH subtype of fatty liver disease, is almost twice as many patients as hepatitis C. So just to put it into context, aminotransferases will be helpful if they're elevated. However, if the liver enzymes are not normal, but you have multiple risks, then that should not actually give you comfort that the patient actually is not going to have bad NASH or progressive NASH. As you just heard, there are patients that actually can develop the cirrhosis. In fact, there is a subgroup of patients that we used to call cryptogenic cirrhosis. These are the patients that all had burned out NASH. They had NASH with normal liver enzymes that no one picked up over the years. So how I do actually screen these patients, if they have fatty liver by ultrasound, if they have abnormal liver enzymes, then I think those patients do have NASH, and we just have to prove that these patients don't have NASH or they're not at risk for progression. On the other hand, if patient comes in to see you and has multiple risks for metabolic syndrome, type 2 diabetics, visceral central obesity, hypertension, hyperlipidemia, if they have diabetes, the prevalence is so high that these are the patients that should be looked at by some non-invasive tests, and we're going to talk about that in a few minutes. But if you have multiple components of metabolic syndrome, the prevalence is then not 37%. The prevalence is 90% or so. So you are very comfortable to say that patients that have 3 components of metabolic syndrome almost for sure will have fatty liver disease. Well, at least 90% of those patients will have fatty liver disease. These are the patients that you can screen. How do you screen them? We'll go over some of the other sort of risk stratification things that you can do in the clinic without relying on things like liver biopsy or anything that's invasive. So there are things that would be available to your clinics that very easily you can look at that and say, this is the type of patient that I need to pay more attention to. The point that Dr. Howell was making, which is very important, is that these are the patients that you're going to see every day in your practice. The fact that they have normal liver enzymes should not actually somehow give you comfort that they don't have advanced liver disease or can have potential to move on to having advanced liver disease. Metabolic syndrome and component of it would be very important in terms of your risk stratification. On the other hand, if you do have abnormal liver enzyme in that context, then that would be even more evidence that these patients are at risk.
Perfect. We'll keep an eye on the metabolic syndrome very closely. Dr. Younasi, a lot of patients come and say, how long is it going to get me to get to cirrhosis or move from pre-cirrhosis to cirrhosis? Do we have data on that?
Yeah, there's some data, and in fact, over about 2 years, about maybe 20% of patients that have significant fibrosis that go on to development of cirrhosis. And of course, cirrhosis is really defined as significant scarring of the liver. Clinical cirrhosis would be sometimes you can have very small varices, the evidence of portal hypertension, or you have platelet count that's slightly low, suggesting hypersplenism, but patient may not have decompensation. So over 2 years, there's probably about, on the average, a risk of about 20% of these patients developing hepatic decompensation. Now, we will review some of the non-invasive tests that can tell you which patients are at risk. For example, there are non-invasive tests. One is called ELF test, enhanced liver fibrosis test that we will look at. And if that's actually more than about 9.8, and sometimes maybe around 10, if it's higher than that, these are the patients who actually would be at risk for progression to cirrhosis. Low platelet count, other non-invasive tests that's called FIB4 or NAFLD fibrosis score, we'll review that. These would be, and the higher sort of scores will be predictors of development of cirrhosis. On the other hand, if you have someone that you know has cirrhosis and you're looking to see if these patients are going to decompensate or not in terms of development of complication like ascites or hepatic encephalopathy, liver function would be, of course, one way to look at that. And these easiest ways to look at albumin and prothrombin time, but there are more sophisticated ways of looking at MELT score or GLP score can actually predict progression. In fact, if there is any evidence of portal hypertension, for example, if you have varices, esophageal varices, that would be a predictor of potential decompensation over time. And again, like I said, there are some non-invasive tests, and of course you're looking at a higher sort of score, the ELF score of more than 11.3, the FIB4 that we will look at that will be higher on NAFLD fibrosis score. They can help you sort of at least risk stratify patients in terms of having risk for progressive liver disease or cirrhosis or hepatic decompensation.
Thank you for explaining this. Very interesting. 2 years, 20%. Those are important numbers to tell our patients. Scott, there are multiple things that are associated with the diabetes and metabolic syndromes, and you guys are the gurus, so I'll let you explain it. Often we defer to you guys helping us managing, but what's the significance of these comorbidities?
I think as a primary care physician, we're at the forefront of the disease. And, we're really placed right in the middle between the cardiologist and endocrinologist, and then the hepatologist, view of the world. So we have to manage diabetes, we have to manage weight loss, and not only that, but we have to manage cardiovascular disease and the risk factors that are associated with it. And when you heard before, many patients with fatty liver disease and Nash, and especially advanced fibrosis, many of those patients have cardiovascular disease and cardiovascular events. And so that to me is a significant reason why primary care physicians, because of the cycle between NAFLD, Nash, diabetes, and that cycle, we have both spectrums that we really have to be cognizant of. One, we have to be cognizant of the cardiovascular disease that NAFLD's linked to. And then we also have to worry about the progression of NAFLD into, hepatocellular cirrhosis and hepatocellular carcinoma. So we as primary care physicians have to be very cognizant. And not only that, but from the diabetes perspective, we always check diabetic eye, we always check diabetic kidneys, diabetic neuropathy, and obviously microvascular disease. But I think in the near future, we really and truly, with a diabetic aspect, we really and truly have to be, doing a diabetic liver check. And that is probably, the way that we can really kind of quantify, how the liver is actually integrating within, the overall spectrum of that metabolic syndrome. And as you can see, this cycle between diabetes and then NAFLD and then cardiovascular disease, it's all integrated into one metabolic syndrome. And so I think we're just shedding on to light right now of how important the liver is in respect to, being almost central to this. And primary care physicians are at the forefront of identifying it and then understanding how this integrates within cardiovascular disease and then hepatocellular carcinoma and progressing from, NAFLD to Nash to fibrosis to cirrhosis. So we're at the forefront of this.
When my patients come to me, actually, they ask me, the first question comes to mind, especially this is a disease associated with metabolic syndrome, obesity, and diabetes. Doc, what should I eat? So this slide shows one of the studies, but in general, there are multiple studies that have been showed the diet association with NAFLD and NASH. So it's known that coffee is anti-steatotic and anti-fibrotic for the liver. So we're coffee lovers, the hepatologists. Mediterranean diet has been studied and emphasized with non-alcoholic fatty liver disease. And low-carb diet recently has shown that it's very helpful with non-alcoholic fatty liver disease. So I actually have a nutritionist in my clinic talk about all that with them. But also the type of food has been looked at. And this is a study we published in Hepatology where we included 2,900 patient cases. Out of those, 518 were cirrhotics. And we had a match of 29,000 patients matched for age, diabetes, yada, yada, you name it. What we found is actually common sense, but it was interesting to find because it has been reported for the first time. So food enriched with cholesterol is associated with the cases with NAFLD with cirrhosis versus NAFLD no cirrhosis. Also, fibers were actually associated with NAFLD with no cirrhosis. So they actually reduce the risk of NAFLD in general, which is not surprising. Next slide, we'll talk to you about other type of foods. And this actually has been repetitive pattern. So the meat and the unprocessed meat has been associated with this group with NAFLD and cirrhosis. And this is an evolving topic in many areas that you guys primary care know the red meat and disadvantages, although I like my steak. All chicken has been associated with NAFLD without cirrhosis, but the red meat was the one associated with cirrhosis. Still, chicken has been associated with NAFLD, but not with the cirrhosis cases. So we're left with very minimum healthy food in these cases. But also now let me tell you about how do I make a diagnosis in hepatology clinic. So there are multiple things I look at. So the first thing, patient walked to my clinic. As Dr. Younossi and Howell alluded very nicely, that do not look at the first thing at the liver enzymes. It's important to look at them, but look at the patient overall. How does he look? What's his weight? If you think he has metabolic syndrome, and then look at the past medical history, diabetes, hypertension, dyslipidemia, especially the diabetes. I call it here, it's the toxic one in my clinic. And what you notice in these patients, actually, they're asymptomatic, or you can miss the symptoms, which are fatigue, some right upper quadrant pain, and a lot of people say it's probably because of obesity and yada, yada. But indeed, Dr. Younossi showed that if you look deep, they have worse quality of care, quality of life in general. So the symptoms might be vague and obscured here. And then I also look at the liver enzymes, and what's important for me, the trend of the liver enzymes over time. So if they are elevated, it's helpful. If they are not, and if they have metabolic syndrome and diabetes, as Dr. Howell and Younossi mentioned, I will be still on my toes. It's important to look at other things. So fatty liver come from alcohol. So you need to quantify. In the guidelines, 14 drink for women a week, 21 drink for a man a week. We actually say it could be less, probably 14 and 7. There are no other competing etiology. And Wilson's disease can give you fatty liver. Medications like steroids and stuff like that can give you fatty liver. So to get the non-alcoholic fatty liver, you need to, rule out other causes. And sometimes we use a liver biopsy to distinguish the 100 million from the 20 million people and see the inflammation ballooning, and as well as the steatosis. However, there are non-invasive testing that helped us bypassing that. We'll tell you about later on. And Scott, I'm telling you what is in hepatology clinic, but you are a primary care physician here and there in different roles. If the primary care physician asks you, Scott, I have so many things to focus on. What do I need to focus on exactly in these patients? We will get to the point eventually how we're going to refer them to hepatologists. But what do you look at now?
Yes, and I think as primary care physicians, and this is starting to pick up and starting to understand, what Nash, NAFLD, and really and truly what advanced fibrosis and cirrhosis have on the morbidity and the mortality of our patients. And so we're treating patients as a metabolic syndrome, but really and truly the goal is really to identify the patients with Nash and to prevent the progression to fibrosis. That's what we really should be doing is the front line. And just looking at liver enzymes, I think we need to go further in depth than just looking at liver enzymes and just saying, just lose weight. And then the second one is we really want to take from, that advanced fibrosis. What was mentioned previously is that there's increased mortality when advanced fibrosis is identified. And so many patients are just asymptomatic, that we see. And I've been an early adopter, looking and evaluating patients for Nash liver disease. And I just have to say that, I just find advanced fibrosis and cirrhosis in many of my diabetic patients that are just asymptomatic. And so I think it's really more of a call to action for primary care physicians to really integrate liver health into their practices. And it's just not, hey, we found something on ultrasound of fatty liver, but really truly understanding that link between cardiovascular disease and diabetes and being in the middle, and the importance of then that identification and then the decrease in progression to fibrosis and cirrhosis. Because once you have advanced fibrosis, the increase in cardiovascular mortality goes up and all-cause mortality goes up. So it's almost essential to have this silent disease that doesn't really and truly appear, to be evaluated, to its fullest extent, and then to make those pathways to hepatologists to, for further treatment. So that's what the goals of primary care are for.
Let's go back and look at George. This guy has type 2 diabetes, 5 years. He has dyslipidemia for 2 years. His mother has diabetes as well. And his exam very remarkable except for obesity. And he gives you this right upper quadrant discomfort. I remember he's a lawyer. He's on metformin, and ALT is 60, AST is 65. Normal albumin platelet, as Scott mentioned, more than 150, but it's not 400. And he has the lipid panel, and the A1C is consistent with diabetes. So now my question for you is the following again. Please vote now and see what would you guys do. Wow, you are ordering ultrasound, and 2/4 of the people, actually to 76%, they got that correctly. So George could have cirrhosis, and you really don't want to miss cirrhosis or even ECC, like Dr. Younafi alluded. And the right first step for this patient, do not ignore that patient, especially he's diabetic, and I will order ultrasound of his liver and the setting of abnormal liver enzymes. But there are other steps that we will go to tell you how Scott know if he is going to refer to Dr. Younafi and I or not. The learning objective number 2 now, and I'm going to turn to the master, Dr. Younafi. So when you do liver biopsy, do we have other options? You mentioned that earlier. Would you please educate us on that?
Sure. Of course, the liver biopsy, of course, is the gold standard. It has been the gold standard for years, and may not remain as a gold standard in the future with better tests. But it has been the gold standard to establish the diagnosis of steatohepatitis, because, as I mentioned, steatohepatitis by definition means fat with ballooning of hepatocytes and some lobular inflammation. So that diagnosis can only be made currently with liver biopsy. So Nash or that component of it is actually going to require liver biopsy. But liver biopsy is invasive. Of course, that there are some sampling issues. There is bleeding and pain. There are costs associated with liver biopsy. It's not a pleasant test to do. And of course, at the moment, the liver biopsy is really, we reserve the liver biopsy for those patients that we enroll in clinical trial, because clinical trials require liver biopsy. When you have a patient that you suspect of having a second type of liver disease, for example, since fatty liver is so common, you can have Nash with autoimmune hepatitis in same patients, or another form of liver disease. So those are the type of patient that we could consider liver biopsy. Otherwise, liver biopsy is really reserved for most of the patient that we would not have an answer with non-invasive tests. Now let's look at some of the non-invasive tests that currently are available. Okay, so you can sort of look at non-invasive tests for Nash into three different categories. The clinical laboratory test, and there are a number of them that I'm going to review in a minute. And one is called NAFLD fibrosis score, or NFS, FIB4, and there are a number of others. But the one that is actually the one that I use very commonly is FIB4. NAFLD fibrosis score is also recommended by the AASLD guidance document for Nash, and it can be used as, again, non-invasive tests. These are the sort of test algorithms that are available in the internet. And they're all based on clinical data that you have available, easy to calculate, and there's actually thresholds that they will give you to consider patients that have significant fibrosis. Now remember, most of these tests that we actually have here is to actually stage fibrosis or determine the amount of scarring of the liver. They cannot tell you if somebody has Nash or not. In general, these are basically non-invasive tests for fibrosis. The second type of tests that we have done are historically would be imaging tests like ultrasound, CT, MRI. These tests will tell you if there is fat in the liver, especially if there is a lot of fat, but really cannot tell you if there is scarring of the liver, which is important. Why do we focus on scarring of the liver? Because scarring of the liver is an independent predictor of mortality. You'll see that maybe in a few minutes. When you reach a stage of 2 or higher, then the risk of mortality and liver-related mortality increases significantly. There is a type of MRI, which is MR spectroscopy, that you can get when you actually order your MRI of the liver, that will actually tell you the amount of fat in the liver. And the other type of imaging that we're looking at is to assess the stiffness of the liver. These are things that will measure by elastography. Transient elastography is the most common one, point of care test, and Mazen, you're going to review that. But the more sophisticated one is the MR spectroscopy or MR elastography, which is probably more accurate, but probably less accessible and also a bit more expensive. Now, there are a number of biomarkers. These are tests that are being developed. Hyaluronic acid, which is a product of fibrinolysis and fibrogenesis. This is a test that will again measure what's going on in the liver in terms of scarring of the liver. The test that probably will become available this year is called ELF score, which is enhanced elastography fibrosis score. This test is already available in Europe, but I think it would be a good blood test that should become available. CK18 was a test that was theoretically was going to determine if someone has Nash or not. That test is really never got validated. So these risks of these tests are not that widely available or used. FibroSpect is available, and actually you can order it. My own sort of feeling is that FibroSpect and clinical practice may not perform as well as some other tests that are being developed or go through the evaluation in the future. So let's look at this question. Going back to the patient, George, I don't expect a lot of people to know about these tests, so it would be good to now just go into what do we mean by the thresholds that we're talking about. So if you look at my right of the slide or your right of the slide, when you look at these non-invasive tests, FIB4, NAFLD fibrosis score, when you have a FIB4 that's more than 3.25, or if you have a NAFLD fibrosis score that's greater than 0.627, 0.72. Both of these two patients would be considered to be at risk for having significant fibrosis of the liver. If you're on the other extreme, which is the left side, if you have a FIB-4 that's less than 1.3 or a NAFLD fibrosis score that's just less than minus 1.455, in general, these patients are considered low risk to have advanced fibrosis. And these are the patients that we really don't need to put through significant assessment. I would actually recommend that these patients are followed, have another test done every 6 months or a year at least. And then you have this group of patients who are in the middle, the intermediate risk. This is where George actually falls. So the vast majority of patients that we see sometimes in the clinic can fall in this intermediate risk. And these are the patients that then need to have the next type of test, which is basically the elastography, the other test that will that Mazen is going to review in terms of how to actually then take these sort of what I call enriching the patient population. So you have someone who comes into your clinic, has type 2 diabetes or have a number of components of metabolic syndrome, or has some fatty liver by some ultrasound that was done for gallbladder, or has limited liver enzyme and an ALT that is slightly up. You do the FIB-4. The FIB-4 is actually either on the high risk or intermediate risk. What is the next step that we need to do? So let's now go back to Mazen and see if Mazen can describe for us for some of these additional tests that we can do. So now coming back here and looking at actually the ALF testing. So when you look at the cutoff point for ALF testing, what cutoff do you consider as high risk for progression? So Mazen, maybe you can take it on from here and describe, review.
Great. This is a great, the question is a great introduction to the next slide. So we hope that this test will come eventually in the United States and the market, as Dr. Ganassi said. The reason is there are multiple studies, large clinical trials in Nash space from different actually agents and different sponsors that showed, to answer the previous question, look at the left. If your patient had a baseline ELF, if less than 9.76, he's less risk to progress to cirrhosis. However, if he had more than the ELF value, more than 9.76, they're more likely to progress to cirrhosis, and that was statistically significant. And the beauty of this test is not just prediction of the progression to cirrhosis. As we told you earlier, within 20 years, the F3 or pre-cirrhosis, 20% go to cirrhosis. But also for the cirrhotics, if you had the value of more than 11.27, you can remember it as 11.3, now you are at risk of developing liver-related clinical events. And those are, you know them, ascites, hepatic encephalopathy, Persia bleed, and death and liver transplant. So important numbers, important to look at in the near future. And we're going down the test one by one and giving you details, but eventually we have a slide to kind of streamline an algorithm in terms of referral on what to look at first. So here we're showing you that how many tests or additional tests we have to confirm fibrosis and move away from liver biopsy. Most of the patients now, they don't get a liver biopsy for confirmation of fibrosis. Indeed, when the test shows that they are less accurate or they are indeterminate zone, as Dr. Ganassi mentioned, you can do another test to confirm, and thus you're moving away from liver biopsy. And those are what I'm showing here, kind of imaging-based fibrosis staging. So on the left upper side, what you see here is what's called transient elastography, or commercially known as the FibroScan. It gives you, you get 10 readings, and the blue number here, it tells you about steatosis. And the orange number, which I tell my patients is what matters to me a lot, is the stiffness that represents fibrosis. For instance, this patient has normal fat as well as fibrosis in the liver. And if they get to liver 14 in orange, that's when they have cirrhosis. On the right, I'm showing you shear wave elastography, as well as RF, which is also ultrasound-based elastography. In the left lower corner, I guess, this is MRI-based imaging called MR elastography. And the beauty of this MR elastography that they put usually a pad on the liver, and it's measure like the stiffness of the liver in most of the liver. So it's very accurate method. Indeed, and I'll move to the next slide. This MRE has now longitudinal data. For instance, if you have a patient that came to you with MRE value of 3.3, a year later, he comes and he has an increase in 15% in that MRE value. That means this 15% or greater, he's most likely at another stage of fibrosis. So these non-invasive techniques now are starting showing not just like value in a stage and tell you where exactly is the patient. Indeed, they have value in telling you if the patient is progressing or not. So which test is better, since we're giving you entire overview of the entire invasive testing? So FIB4 is actually better than clinical prediction tests like platelet and albumin and all that. And it's fairly accurate. And this is what we would like you to remember today, in addition to other tests, but this is probably one of the first steps. The transient elastography is an imaging technique which is better than FIB4 in terms of accuracy. That's what the data showed. And a model elastography is more accurate than FibroScan in some studies. So again, I mentioned this concept. You have all these tools in the kitchen that you can confirm the stage of fibrosis, and you may move away from liver biopsy. So from your standpoint, you can use multiple formulas. Else, eventually, when it comes, transient elastography is available to confirm the stage of fibrosis and make sure your patient is not at risk of progressing to cirrhosis or liver cancer. So let's move to the money slide. What we think is, in general, many experts in the field believe that metabolic syndromes and diabetes are a great risk factor for non-alcoholic fatty liver disease. The European guidelines started at the age of 50, saying everyone with diabetes and metabolic syndrome more than 50, you need to move to the next step. I think age will change with time, and I will be left with all diabetes and metabolic syndrome probably should be looked at. So you can do what you do. You guys are all good at that. You do ultrasound and ALT. And then sometimes the ultrasound comes back, it's like, boom, cirrhosis. You sent to the hepatologist right away. And we have seen tons of that. What Dr. Yanasi called cryptogenic cirrhosis, that was discovered for many years. If the ultrasound and ALT are normal and they're showing for fatty liver, this patient has these features. You can, the diabetes and the metabolic syndrome, you can just, manage them. You guys are the experts in this. And we always turn back to you and ask you what we should do. Now, if you discover fatty liver on these tests, this is what I call it the diagnosis. Now we're moving to risk stratification. And the most usable and easy formulas and FIB4 and NAFLD fibrosis score. You actually can just go to Google, plug in numbers. Those include age, liver enzymes, platelet number. One of them includes diabetes status. And it will tell you what's the value. So one thing, I don't want you to, the values, if you take the slide picture or you look, you'll find the values. Slight adjustment from the previous slide, that any value more than 2.67, the previous value was in hepatitis C, some Nash, but then with Nash, a FIB4 more than 2.67, that should give you a red light pause. You need to send this patient to a hepatologist. Or you can use the NAFLD fibrosis score, more than 0.676, you send them to the hepatologist. This patient has advanced fibrosis until proven otherwise. We're here to help you. Let's move to the green light, which is the majority of the patients. You diagnose fatty liver, and then the values are less, the FIB4 less than 1.3, you don't have to worry about referring weight loss and exercise will do. In the middle, the yellow light, which is the intermediate that you have to be careful, is the values in between. Here, again, to the concept of you can do another test, elastography, ELF. If you don't have them, prefer. But these yellow and red light should tell you that those patients are belong to the hepatologist, and we're here to help you. So now Dr. Younasi informed us in a great deal. We don't have to do biopsies. This algorithm does not show any biopsy, and you are risk stratifying. And Dr. Younasi showed these values. So let's see if we now know the magnitude of these values and what do we do with these patients. So outstanding. We're doing great. So those are the values that the 2.1 falls between the 1.3 and 2.67. This is the yellow light in that value. The NAFL score or NAFL fibrosis score also fall within the intermediate risk. So these patients you're not done yet. You're not on the green light. These patients are the patients that will likely need another step. If you have it, do it. ELF elastography. If you don't, please refer to the hepatologist. With that, we reach the end of our learning objective. We're finishing with another objective for today. Dr. Younasi and I will talk about options for these patients. To understand that, let's talk about the pathogenesis, which is going to be the next slide. So look at the left side, and this is the 100 million people on the left side. What you have here, look at the top, you see increase in the food intake and calorie intake. In the middle, you see this DNL sign, which is increased de novo lipogenesis. One of the jobs of the liver is to make fat. In fatty liver patients, this process is augmented. And you see those arrows, the pathways, are very important because the liver makes more fat. These arrows, actually, the enzymes that support these pathways, are targets for Nash therapies. So that's an important one. Also, you see the adipose tissue delivering more free fatty acid to the liver, and the liver has to handle them in the mitochondria. And finally, you get this triglyceride excretion abnormality. They get stuck in the liver, and they don't get excreted in the blood as VLDL. Now, those are the 100 million people. On the right side, the people that are risk, metabolic syndrome, diabetes. So they get something called the second hit. Now we call it the second multiple hits, such as oxidative stress, iron overload, the mitochondria is damaged, you have GNK and ER stress, there's a big field of the microbiota, there is genetic abnormalities. All these lead to the second phenomena, which is NASH. And this is you see like these red spots, all those are the inflammatory mallow that will lead to fibrosis and cirrhosis. And now, let me show you this on a better kind of scheme with explanation. You see here the liver, and this is George's liver. What happens with George's liver, he increased calorie intake, you increase de novo lipogenesis, but then George's liver, and you see here the fat started accumulating, more triglyceride, gets fatty liver gets enlarged from fatty liver. Not everyone goes to NASH, but some people, they have this inflammatory process, and you start seeing these inflammatory cells getting activated and recruited. Now they're secreting cytokines for you. And you have this inflammatory response, we call it the inflammatory mallow in the liver, NASH, that lead to cell activation, myofibroblast, more fibrosis, eventually the liver gets to cirrhosis after the cell activation. Now let's look at options. This is the pathophysiology. This is what's called the FXR receptor. And here, the FXR receptor is a nuclear receptor. You see the bile acid in green came with the yellow one, which is activator, and remove the corepressor. The FXR receptor is a bile acid organizer, and regulating bile acid has a role too in lipid metabolism and glucose metabolism. So FXR agonists that target the receptor in the liver and the intestines have been shown that they reverse steatosis, fat, reverse inflammation, reverse fibrosis. So you will hear multiple talks about FXR agonists in the liver. Let's move to another target. PPARs receptors, the nuclear receptors, pioglitazone does belong to that family. So let's talk about the receptors. Again, you get a fatty liver here in George's liver. You have fat accumulation, and you get more fat. One of the jobs for the PPI receptors, alpha delta, is to metabolize free fatty acids with the mitochondrial help. So if you have effective PPAR alpha delta, here it takes care of the free fatty acids, it processes them, it metabolizes them. However, if the PPR alpha or delta or alpha and delta, they're defective, you see these free fatty acids not getting processed. They are now in the liver, getting stuck, causing more fatty liver, more fat accumulation, and then the inflammatory cascade that stimulates stellate cells and myofibroblasts and fibrosis. I want to show you another target. So there are multiple targets we can hit, but again, you start getting the fatty liver process, more fat, triglyceride inflammation, and then the inflammatory cells get activated. And you see these two ligands, CCR2 and 5 receptors on inflammatory cells. What they do is they activate recruitment and activation of other cells. In this condition, this is a Kupffer cell that started maturing, as you can see. The Kupffer cell does not stop there. It says, hey, let's activate others, and let's recruit these monocytes. And the monocytes now are getting recruited on the liver, turning into macrophages, and the other inflammatory cells, they keep secreting the cytokines. Again, you have this inflammatory mallow in the liver. You get more fibrosis over time, while these processes are going, and you see cirrhosis eventually. So those are kind of George's liver and from inside, co-reality within the liver. But what we should actually look at is, let's look at more details. This is just to show us 3D. But look at these drugs that Dr. Younofi is going to tell us, and tell us how many options these patients have.
So thanks, Mazen. Yeah, so those are the important targets, and it's important to know that in a single patient, maybe one or multiple targets could be activated. So this is another important sort of aspect of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, is that it's not a simple and a single disease. That could be a very complicated and heterogeneous disease. So some of the drugs, and this is actually a list of drugs that's not actually very complete, but we'll just go over some of them. Some of them have already been completed, like the ASK1, the selonsertib. We're going to hear about that phase 3. Loxol2, which is simtuzumab, was a antifibrotic drug, and that was not actually successful. There are a number of drugs that will target insulin resistance, such as the PPARs that you just heard about, pioglitazone, liraglutide, and semaglutide, which is GLP-1s. They're primarily in phase 2 data that's out. At least semaglutide is going through phase 3 currently, and we should have something available. The FGF21, which is basically a type of target that technically can help with fibrosis and with fat. FGF19 again would be a drug that will target lipotoxicity and oxidative stress. The FXR is probably the one that is the most recent one that has been already presented. Before going to FXR, I'll also mention the thyroid hormone receptor beta. agonist, which is actually very important. There are a couple of those. MGLT196 is the one that is actually going through or will start to undergo phase 3 quite in the near future. And again, it is a drug that will target lipogenesis and lipotoxicity. It's important that in the future, not one drug will be used as a single drug to treat. It's possible that multiple drugs will come as combination regimen. Let's look at the FXR agonist, the obeticholic acid data. Now, before going that, I'll just let's look at the question. Okay, now let's just look at some of the targets, as I mentioned, out of 4 phase 3s that we have had. 2 of them already has been completed in terms of data. Let's start with ASK1 inhibitor, which was a drug called Solonstitep, developed by Gilead Sciences, and it was targeting patients with stage 3 or stage 4 pre-cirrhotic and cirrhotics, Stellar 3 and Stellar 4. I was the PI for Stellar 3, global PI. Unfortunately, this drug did not meet the fibrosis endpoint of the study for both cirrhotic and patients with advanced fibrosis. So that program has been discontinued. Obeticholic acid, we will review that in a second, but the other 2 drugs that are currently ongoing, the CCR2, CCR5, phase 3, the Sinekiroc drug, that of course is currently ongoing. This study has not been finalized, and we expect that the data will be out sometime in 2020. Elafibranor, the dual PPAR, is undergoing in terms of phase 3 as Resolve It. I think you'll see some data in phase 2. That study is not also complete at the moment. Let's just now look at obeticholic acid in terms of the data that we currently have. So the first study that actually made quite a bit of wave in our field was the study, the Flint study of obeticholic acid, which was a study coming out of the NIDDK, and in this 72-week histologically based phase 2 study, obeticholic acid was compared to placebo, and the study was actually had to be early terminated because obeticholic acid showed significant improvement in a number of histologic endpoints, including resolution of Nash. There was also improvement of fibrosis. This led to development of a phase 3 clinical trial, which is an outcome study called Regenerate. Regenerate actually is a randomized clinical trial, and we can see this in the study design here. So it's a 3-arm study, placebo, OCA or obeticholic acid 10 milligram per day or 25 milligram per day. About 2,400 patients have been randomized 1:1. The study is an outcome study, and it's ongoing currently, but after 18 months of the protocol, a second liver biopsy was actually performed per protocol. It was an interim analysis, and the primary endpoint of the study was one of the 2 things. Either the patient had improvement of fibrosis by 1 stage without worsening of Nash, or resolution of Nash without worsening of fibrosis. If you met one of these 2 endpoints, it was important. It was an important endpoint, and the FDA had agreed that either one of those endpoints could actually consider to be successful. The important thing about resolution of Nash is that that's a very difficult endpoint to meet. However, when you look at one of the primary endpoints, the improvement of fibrosis by 1 stage or more without worsening Nash, then the 25 milligram arm of this study actually was almost twice as much as better than placebo. So the study met the endpoint. Now, when you look at the steatohepatitis resolution or Nash resolution without worsening fibrosis, that endpoint was not met. But again, it was not necessary to meet both endpoints. One of the 2 could make the study a success. Again, I'm going to come back to the point that when you talk about steatohepatitis, it is very difficult to actually meet the endpoints. But when you look at the specific pathologic features of steatohepatitis, like ballooning or inflammation, then you actually will see that the OCA 25 milligram actually met each one of those endpoints. When you look at this right side of the slide, when you look at fibrosis improvement versus fibrosis worsening, remember I mentioned that sometimes patient can actually worsen fibrosis spontaneously. When you look at the placebo group, that happens in about 20% of these patients. So 20% of patients actually improved, and 20% of patients worsened spontaneously with placebo. On the other hand, when you look at the 25 milligram arm, only 13% of patients worsened in terms of fibrosis, while 38% of patients improved. So almost 3 times improvement versus worsening. So there's another evidence to suggest that this drug is actually an antifibrotic drug and can actually help quite a bit in terms of fibrosis. Now, let's look at some of the other profile of of course, of this drug in terms of expanded ITT. This is basically some patients in this group had stage 1 fibrosis, but had to have other components of metabolic syndrome like diabetes, etc. So although I presented the first study at last year's 2019 International Liver Congress meeting in Vienna, this was a subsequent analysis that Dr. Arun Sanyal presented at the liver meeting, AASLD meeting in Boston this year. And again, when you even look at the expanded study and you look at the improvement of fibrosis, you see that it's actually the 25 milligram arm actually meet improvement of fibrosis this time. In fact, when you expand this population, you'll see that the 25 milligram arm now actually even meets the Nash resolution part of the study. When you look at the side effect profile of this compound, which is summarized in the next slide, there are a number of things that people are certainly talking about in terms of side effect. Obeticholic acid, as you know, is already approved for treatment of primary biliary cholangitis. So pruritus is actually one of those side effects that can still exist, but most of the side effects in this study was very mild. There was some patient that had some side effects, and when you look at pruritus, the 25 milligram arm of the study did have a larger amount of pruritus, but again, most of those pruritus was actually quite mild and did not require discontinuation. The discontinuation happened, but it happened in less than 5% of patients. The second, of course, side effect that we talk about is dyslipidemia. That again happens more commonly in patients who take the 25 milligram arm of obeticholic acid. However, when you go back and actually analyze those patients and see if they were managed with statins, you see that those patients actually lipid profile actually become normal, and sometimes it actually become even better than baseline with the management of with treatment of sulfastatin. So both side effects of pruritus and dyslipidemia related to obeticholic acid are easily manageable, and in clinical practice, of course, once this drug is approved, currently it's actually going the FDA consideration for approval. I suspect that these there will be guidance to clinical practitioners of how to manage these things, but in general, the pruritus is mild and the dyslipidemia is manageable and can be managed with statin treatment. Mazen, maybe you can review some of the other compounds that we talked about. You have the data.
Sure. Very important phase 3 study that was successful. Dr. Yunasi presented. I will move to the other pipeline medications. Now they're in phase 3. This is elafibranor. I showed you the PPAR, alpha and delta pathway, and elafibranor now is in phase 3. We're waiting the results that are expected to come out soon. Nevertheless, let me show you the phase 2 that they're based their progression to phase 3 on. So this is called the Golden Study, and they enroll patients here on placebo, 80 milligrams of elafibranor, and 120 milligrams. So on the left, the initial primary endpoint was not met. However, after ad hoc analysis, you see here 19% of patients on elafibranor, 120 milligram, improved their Nash histology assessment compared to 12% of the placebo. So this is, again, PPAR alpha and delta pathway drug, and the phase 2 study was, after ad hoc analysis, was positive, and they moved now to phase 3. We're looking forward to these results. Next slide, we'll talk about CVC. Waiting for the next slide. I showed you this CCR2 and CCR5 ligands, and if you block these receptors, it might improve Nash and inflammatory pathways as well as fibrosis pathways. So here, the drug CVC. Now, this is a phase 2 study. On the left, what you see is the CVC compared to the placebo did not improve Nash, the steatohepatitis. However, on the right side here, it shows you that there is improvement in fibrosis, and I want to highlight the right two columns, 20% and 10%, and the 20% versus 10% in that study was statistically significant on a CVC of 100 milligrams. They have extension studies as well that show the people that they stayed on the CVC 150 milligram continue to show beneficial effect. And that's why now they are in phase 3 as well. The selonsertib is an agent, and it works on something called ASK1 pathway. So there are ASK1 inhibitor. The ASK1 pathway works on GNK, so it's inflammatory pathway, apoptosis, this pathway, and eventually affect fibrosis. So in this study, there was 18 milligram, there was 6 milligram selonsertib, and they compared it to a drug called simtuzumab, which was the comparable placebo. The reason why they consider it as the comparable placebo is because simtuzumab did not work in a previous trial. And here on the left, you see improvement in fibrosis by one stage, and there's a question from the audience. How much is good for fibrosis improvement? It's one stage on histology for clinical trials. So it is 43% compared to 30% compared to simtuzumab that's considered placebo. And you see here the magnitude in the 18 milligram. On the right, they looked at it in a different way, which is if you progress to cirrhosis or not if you are on the drug. So the simtuzumab, more people progressed, that was 20%. Again, that was considered the placebo. And compared to the 18 milligram was only 3%. So that magnitude led to the design of the phase 3 trial of selonsertib. So the phase 3 trials of selonsertib were two trials technically. On the left, Stellar 3. On the right is Stellar 4. Stellar 3, as it sounds, it was targeted with people with F3 fibrosis, which is pre-cirrhosis, versus Stellar 4 targeted cirrhotics. Those are too high bars because they're advanced fibrotics. Unfortunately, the trial did not meet the primary endpoint of fibrosis improvement, neither in the Stellar 3, which is the F3, or nor the Stellar 4, which is the cirrhotic group, and the drug was comparable to the placebo. That will not be the last phase 3 trial that will fail. Other trials in cirrhosis have failed as well. So it shows the challenge, some of the challenges we are encountering in this field. So one important point, again, this is actually, we learned it from you guys, the primary care doctors and the endocrinologists, if there is any endocrinologist on the audience today. This NASH disease is a metabolic disease. So we started thinking and learning from you. It's like similar to diabetes. When we started in the diabetes field, luckily we got metformin, but that was not enough. We then started adding the PPARs. We started adding others, SGL2s, GLP-1s, to improve diabetes, reach the targeted A1C, and improve cardiac outcome in this disease. We believe the same is going to happen in NASH, that you're going to target multiple pathways and combine the drugs for instance inflammatory pathway and fibrosis pathway, or steatosis pathway, or someone combine multiple. And there are actually attempts and trials are in the pipeline. So, for instance, you have here one of the trials that is just finished, solonsertib plus, which is the ASK1 inhibitor I told you about, plus FXR agent, plus another agent called ACC inhibitor, which targets the fat processing in the liver. They combined these drugs, and there was a recent assessment of some positive signal, although it did not meet the primary outcome. Other drugs, the PPR alpha delta, you might want to combine it with FXR, and there are efforts to do that as well. And the CCR2, CCR5 receptor blocker has been also combined with FXR agonist. So it is an exciting field. It is an evolving field. We'll see more trials ongoing, and eventually we will get to the bottom and improve people. So let's go back to George. And Scott, you asked me, what do I do? Do I have options? So let me tell you the way I look at it today. So George, the lawyer, came to you and he said, I have all this. You performed ultrasound and liver enzymes. And then you looked at the risk factors, like, George has diabetes. I better go to Google to fit for a NAFLD fibrosis score. You can talk to him about his drinking habits. You rule out other causes. Then, based on the NAFLD fibrosis score and FIB4, of course, ultrasound showing fatty liver, you can refer him to a hepatologist based on these results. You can start talking about the diet and exercise. We talked today about which diet to use, such as Mediterranean diet, and low-carb diet, and the type of foods. However, also, George might have other options in the near future. For instance, if a NAFLD fibrosis score in the intermediate zone, you can do another test, transient elastography, others. One of the tests that might come is ELF, and possibly in the future, obeticholic acid or other agents. We're getting tons of questions today. I already took a look, and I'm impressed with the level of the questions we have, actually, and the amount of the questions we have. So thank you for your interest. So Dr. Younossi, let me ask you this question. One of the people, or multiple people asked here about the obeticholic acid study. And they asked if these, I'll read the question for you. Did all of the trial subjects in obeticholic acid studies have type 2 diabetes? What kind of a fibrosis, improvement in fibrosis is meaningful? So if you can explain that again. And do you think we will have treatment in 2020 and 2021?
Yeah, so not all patients with who actually entered the study actually had diabetes. So diabetes was not a requirement, but as you would expect, about 25-30% of these patients can have diabetes. What was required, at least for a patient to enter, was to have steatohepatitis by biopsy and have stage 2 or 3, not stage 4. And if you had stage 1 and you had one of the components like diabetes, then that would be the subgroup that was allowed. So that's the first part of the question. In terms of what is actually meaningful in terms of fibrosis improvement, I think most of the studies have shown that if you actually have improvement of fibrosis by one stage or more, that's actually clinically important. For example, if you have someone who has stage 3 and you get that patient to stage 2, that's actually clinically important in terms of outcomes. Are we going to have a drug, maybe specifically obeticholic acid, available in 2020? The drug is undergoing approval process right now, so it's in the hands of the FDA and the drug manufacturer. It is ongoing. I expect it to be available sometime this year, maybe hopefully as early as this summer. But unfortunately, we're in the COVID time, so things are changing. But I expect that we will have something available this year.
Thank you very much. And I'm getting multiple questions on the role of vitamin E and if it's any good. So do you mind touching base on that? And someone asked a question about GLP-1 as well. So do you mind explaining that?
So vitamin E, of course, there's been a number of studies as an antioxidant that could potentially have a role in non-alcoholic steatohepatitis. The best study that actually showed some efficacy was in Prevalence, which was a study again from the NIDDK, NIH. And I actually think that there they use it as a second placebo to compare it to pioglitazone and of course placebo. And in that study, actually vitamin E, 800 international units per day, actually performed better than placebo. So for that reason, and this group of patients were non-diabetic and non-cirrhotic. So for non-diabetic, non-cirrhotics that have NASH, I certainly use vitamin E. Of course, there is also concern about potential side effects, and those have not actually been proven to be entirely true for patients with NASH. You have to discuss that with the patient in terms of any potential risk. But I think in clinical practice, I certainly use it for NASH patients who are non-diabetic and non-cirrhotic. GLP-1s, liraglutide was the first drug that actually showed in phase 2 that there was some improvement of histology. Most of that improvement was associated in terms of improvement of both weight and in terms of also improvement of insulin resistance. Semaglutide which is actually the better regimen, and it's actually it has shown to actually cause at least 15 to 16% weight loss. And some patients is currently undergoing a clinical trial and in some of the analysis of the other studies, there is actually improvement of liver outcomes. So I suspect that semaglutide or other GLP-1s like semaglutide would have a major role in the treatment of non-alcoholic steatohepatitis in the future, because it does get to the root of the problem, which is basically obesity and type 2 diabetes or insulin resistance.
Yeah, so I will ask a couple of questions quickly, and then I'll ask Scott a question. So the multiple people are asking about if FIB-4 and NAFLD fibrosis score improve with weight loss and exercise, or even with a drug. There are studies that show they play a prognostic indicator in terms of they improve as well. Indeed, the Regenerate study showed improvement in the FIB-4 in the responders. There's a question about the cost of 3 biomarker tests, question mark. I'm not sure what's the biomarkers, but NAFLD fibrosis score and FIB-4 are free. You can go online to Google and say LTAST age formula, and you can just enter them. Scott, there's a question about the availability of transient elastography and cost. So do you want to take that?
Yes, Mazen. I think as primary care physicians, as internists, looking at that liver health and, getting the ultrasound, the FIB-4, and when that's indeterminate, getting the elastography to me is what I do in clinical practice, when I have those indeterminate results. And that tells me, of those two values, the stiffness score and the fatty acid or the fat score. And that really helps me, determine which patients I then send further to the hepatologist. And so at present time, elastography is mostly within the hepatology domain, but bringing that into the primary care where I've been part of, and I do elastography in the office, I think could then increase the access to identifying the correct patients that then should go to hepatology for referral.
Let me close with 5 SMART goals. And I would like to give the audience and maybe take home message before you move to your next Netflix show. So for diabetic patients, where we in the Liver Society believe that these patients should be looked at and screened for NAFLD and NASH. Of course, you guys are the best in consulting them on the type 2 diabetes, the medications, the weight loss. We don't want them to get to NASH, fibrosis, and cirrhosis and come to us. But the message really tonight is, please don't let them just be in the primary care for many years. Now we know the disease, we're aware of it. just stage them. And it's on Google. You can just go to fibrosis score and you'll find those. And we showed you today the referral pattern for the hepatologist if you suspect advanced fibrosis based on easy formula. And we actually need you. We need you to help us monitoring these patients, referring them, and we'll get back to you also co-managing the diabetes, dyslipidemia, cardiovascular profile. It's a real disease, a whole body, multiple organs, and we need partnership. With that, I would like to thank CME Outfitter for this great night and give us the opportunity to explain the disease. I would like to thank them for Augmented Reality. Hopefully it showed you George's liver very well. And of course, I'm privileged and honored to have both Dr. Howell and Dr. Younossi today, leaders in primary care and leaders in liver disease, enlightening us and educating us about this liver disease. I'm very grateful to you guys. And thank you very much, everyone, and have a good night. And please stay safe and well during this pandemic.
Thank you.
Thank you.
Thank you.